Welcome to McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum built for residents and fellows from PGY 1 to 5. Today's topic on toxic alcohols is brought to you by Bandar Ba. After this module, learners will appreciate when to suspect the ingestion of a toxic alcohol based on history, physical exam, and diagnostic tests. They will also have a management approach, including which specific antidotes to use. Let's go through a case to start. A 54-year-old man who is known to the ED as an alcoholic is brought in after police found him asleep and not responding beside the downtown shopping mall. He has an altered level of consciousness with only a slight response to painful stimuli. On exam, he is tachycardic and tachypneic with a borderline blood pressure. You find no signs of trauma and no obvious cause of his LOC on the remainder of the exam. Your toxicology blood work comes back and reveals the following results. Please note the VBG, osmolality, and alcohol level. The hallmark of a toxic alcohol ingestion is the presence of a severe metabolic acidosis, a high osmolality, and a minimal alcohol level. This is clearly not responsible for his level of intoxication and altered mental status. Whenever there is a metabolic acidosis, your automatic next step should be to determine if there is an anion gap. The finding of an anion gap metabolic acidosis narrows down your differential diagnosis. Several mnemonics exist to help you remember this list, such as mud piles or Goldmark. Feel free to use whatever works for you. Key toxic causes of an anion gap metabolic acidosis are toxic alcohols, iron, cyanide, and salicylates. Now on to osmolality. The presence of an anion gap metabolic acidosis and a high osmolality should trigger you to calculate an osmolar gap. The osmolar gap is the difference between the measured and calculated osmolality. Thinking back to organic chemistry, remember the osmolality is a concentration of a solute in a solution. Therefore, the osmolar gap is asking if there is a difference between the expected or calculated and measured solutes in the blood. These are substances that are unaccounted for in the formula. To determine the calculated osmolality, we use the equation 2 times sodium plus BUN plus glucose plus 1.2 times alcohol. Since alcohol raises the osmolality, we have to correct for it with a factor of 1.2. You can use the saying 2 salts in a sugar bun to help memorize this equation. In our case, we found that there was a high measured osmolality and an osmolar gap. High osmolality is measured when there are extra osmotically active molecules in the blood, such as alcohol, toxic alcohols, mannitol, and amino acids. These are substances not usually present in human blood, so their presence will change your lab values. Now we've confirmed the presence of both a high osmol gap and an anion gap metabolic acidosis. This is commonly called a double gap. Having a double gap further narrows the diagnosis to most likely be a toxic alcohol, such as ethylene glycol, methanol, or propylene glycol. You send off toxic alcohol levels and the lab confirms your diagnosis with a methanol level of 24. Methanol is a chemical well suited to dialysis due to its rapid absorption, fast distribution, and low protein binding. The pathophysiology of methanol is essential to understanding its toxicity. As you know, methanol is an alcohol, and as a parent compound, it's not toxic, but its metabolites are. In the liver, methanol is metabolized by alcohol dehydrogenase and then aldehyde dehydrogenase to produce formic acid. This is the toxic byproduct that causes most of the toxicity, including a severe anion gap metabolic acidosis, retinal injury, as well as basal ganglia lesions. With the help of folate as a cofactor, a small amount of the formic acid gets converted into CO2 and water, but not enough to prevent toxicity. Okay, on to our next case. A 24-year-old man comes in feeling generally unwell after drinking some blue liquid in his fridge that he found after a party. His heart rate is elevated and he looks sick, but has no specific findings on physical exam. On his blood work, there are signs of renal impairment and a metabolic acidosis. As we mentioned earlier, the next step is to measure the anion gap, which is 30, and then the osmol gap, which is 50. A metabolic acidosis with a double gap narrows down our differential. In cases like these, some point-of-care tests or old lab settings may give a falsely elevated lactate level, which can be a hint to think about ethylene glycol ingestion. Pieces of this case that lead you to the diagnosis of an ethylene glycol ingestion are a history of an unknown substance, intoxication, low alcohol plus a double gap, and a high lactate. Similar to methanol, ethylene glycol has properties that make it a dialyzable toxin, such as rapid absorption and low protein binding. Just like methanol, ethylene glycol itself lacks any toxic effects. It has to be first metabolized by alcohol dehydrogenase to produce the toxins glycolic acid and oxalic acid. These byproducts cause a severe acidosis and injure organs like the kidney, causing an acute renal failure. Pyridoxine and thiamine are cofactors that have a minor role in the detoxification of ethylene glycol. The decision to treat a suspected toxic alcohol ingestion doesn't require a specific level. However, levels do help confirm the diagnosis and guide your treatment. Managing a toxic alcohol ingestion should follow these three priorities. First, correct the metabolic acidosis using sodium bicarb. Then, block the action of alcohol dehydrogenase with fomepizole to prevent further production of toxic metabolites. And finally, you should initiate hemodialysis to remove the parent and toxic byproducts. Hemodialysis also results in the correction of any acid-base disturbances. We mentioned using fomepizole to block alcohol dehydrogenase, but if it's not available, ethanol can be used as a substitute until dialysis can be initiated. Ethanol works because ADH has a much higher affinity for alcohol and will preferentially metabolize it over ethylene glycol. The questions for you to work through are 1. What are the possible 2 scenarios of toxic alcohol ingestion that can have no osmolar gap? 2. What are medications that help facilitate detoxifying ethylene glycol and methanol? And 3. List 5 reasons why using fomepizole is better than ethanol in toxic alcohol ingestion. And that's it. Thanks for watching.